Okay, thank you everyone for joining us today. Today we have Dr. Basem Azab joining us from New York in the States. We will be talking about technical pearls and gastrectomy operations for cancer patients. Thank you, Dr. Basem, for joining us for the, I don't know which, third or fourth time at least.
Maybe tense.
Al- yeah, always a pleasure to have you with us, and the
Thank
floor
you.
is yours.
Thank you. So I think my audience, mostly surgical oncologist. Um, I would like to know also what your practice in Egypt. So uh, so we'll talk about things that I think it's not far from what you're doing every week. So the sewer classification, type 1 and type 2, we treat as esophageal. Type 3 is a gastric. The C word, we're looking for the epicenter of the tumor. Sometimes when you look with the scope, which I recommend anyone doing any surgery for stomach, gastroesophageal junction to definitely have to visualize that tumor you're dealing with, because description of some endoscopist is not the best. I would highly recommend you go to someone expert to describe exactly where is the tumor. I think this is the time that someone like Dr. Khalid, I will consult with someone who's really I trust, and give me exactly where is the epicenter. 5 to 1 centimeter, the epicenter above the GE junction, or within 1 to 2 centimeter above and 2 centimeter below the GE junction, or it's really between 2 to 5 centimeter below the GE junction, the epicenter. For only type 3, I will treat as a gastric. The other type 1 and 2, I will lean toward treat them as esophageal with a cross-trial regimen, either Lewis or transhiatal. We have to be familiar with the TNM. This is like bread and butter now, and I think all the cases of gastric cancer end up with having EUS. 5 layers, like 3 white, 2 black. I always like when I teach my residents here, I say, well, the minority is black, the majority are white. So you have 3 white, which mostly not muscular, and the minority, like, which is muscles, the muscularis mucosa, and also the muscularis propria. Uh, so we'll show you like one of the examples. This is on the left side is a normal EUS, and the right side
We
you could
don't see
see.
your screen. Can you start sharing your screen?
Oh, okay. Let me see. Okay. So thank you. Share screen. Sorry about that.
Okay, can we flip through
Yes,
all the slides before quickly
yes, sure.
and make it full
Do,
screen? Yes, perfect.
do you see it now?
Yes.
Okay. So this is the C-word 1, 2, 3. You see like this is what type 1 and 2 is treated as esophageal. Type 3 is gastric. This is the endoscopic ultrasound that is a kind of a must now with our gastric cancer patient. This picture showing on the left side is the normal, on the right side is the cancer, and you could see here white line is preserved, so it is a T3. Invading the serosa will make that uh, T4. I always ask my endoscopist, advanced GI, to do endoscopic ultrasound of the lymph node, and if it's positive, like if they suspicious clinic endoscopically, ask them to do fine needle aspiration cytology rather than biopsy. I think the cytology give you a better yield, because when you stick these lymph node with a bigger needle, they tend to just be pushed away and not really good biopsy with the fine needle aspiration biopsy. So I would say for TIS and T1A, EMR or endoscopic submucosal dissection is a way to go. I would really re-emphasize is not for unfavorable histology. So if you have someone with a diffuse pathology, if you have someone with a signet ring, if you have someone who's a poorly differentiated, this is not the patient that you're looking for. You're looking for someone with well to moderate differentiation, tubular intestinal type, favorable histology, and someone with experience. And the last thing you want to do for any gastric patient, give him a poor surgery that not oncologically safe, and that will end up with losing the chance for cure. And I think the gastric cancer is so challenging. It's a big organ. Not all the time you feel like satisfied when you cutting that part of the body, and you feel like, did I miss something? Did I do all that work in vain? And I will show you some examples. This is the Japanese guideline. Let me move this away. You could see here. Do you see my arrow?
Yes.
Okay, so the Japanese, they go all the way to T4, T1, T2, T3, T4. They recommend all of them gastrectomy upfront surgery. The only time I see them, they go for neoadjuvant chemotherapy when it's a bulky lymph node. It's amazing. This is completely different than what we do here. As you're aware, the National Comprehensive Cancer Network, NCC guidelines, is like, look at here, like T1B, you go surgery, T2 or higher. So as long invaded the muscle, even a little bit of the muscle, they consider as a category 1 to go for preoperative chemotherapy, and even sometimes radiation as a category 2B. But most of us who use neoadjuvant approach in the United States, I have some patient, I have not used it. If they decline the chemotherapy or they have obstruction or certain other indication to upfront surgery. But ISMO and American guidelines recommending T2 and above to go for neoadjuvant, even N1. Remind me to ask you what you're doing in the Egyptian practice or Middle Eastern, if you heard something else, because I think pathology is different. If I deal with Hispanic population has like a very aggressive biology here. Many times is not a good outcome. Asian, they have better outcome. Like when I say Asian, I'm talking about Japanese, Chinese in this area, Southeast Asia, including Philippines and so on. This is a letter of we came with neoadjuvant. The British came first, then French, and finally the Dutch trial. The FLOT regimen is what we think all of us now is better for most of our patients if they have a good performance status. MD Anderson group, they like to do full FOX. Dr. Ajani and his group, they favor full FOX, but actually the majority of surgical oncologists, medical oncologists, if they give neoadjuvant, they advocate for FLOT regimen, which we think has higher pathologic complete response and survival. Look at the 5-year survival here, like almost half of the patient with gastric cancer candidate for surgery, half of them almost, they will live 5 years. This is kind of great news. We never had that before. This is a comparison between the British, the MAGIC trial and the CORE trial, and chemotherapy versus surgery. Of course, now we do confirm chemotherapy and surgery superior than just the surgery alone. This is a FLOT regimen. It's a 4-cycle of FLOT before, 4-cycle after. Actually, sometimes now we do modification of that. Sometimes I give all the FLOT up front. If the patient responding, doing well, we finish it before surgery many times. The FLOT survival, really impressive. And this FLOT regimen is compared not to surgery alone. No, compared to surgery and chemotherapy. So FLOT is superior to the MAGIC trial regimen. So it's really impressive. I will go to once you have this decision, you're going for upfront surgery or neoadjuvant. Sometimes you're facing some scenarios like this gentleman, Hispanic gentleman came on the left side. You see the pylorus mostly closed. This patient had nausea, vomiting, terrible time. Retrospect, I regretted that we placed the stent. This is an uncovered stent. In the beginning, this was thought to be inoperable. I had it in my mind to give him chemo and go after. I was not happy when we put a uncovered stent instead of covered, because it turned to be eroding. You see some bucket of gas here, eroded through the like pylorus duodenum. And when I took him back again, there was deposit on the pancreas. This patient, the way he died was miserable. He is Hispanic of origin, is usually had a bad disease, but this patient tolerated for 6 months with no carcinomatosis. I wish you can avoid uncover the stent in these patients. If you go for surgery, go for surgery. If you can do gastrostomy and jejunostomy, I will advocate for that. And I will avoid stent unless you have like diffuse metastasis, you'll never get to the OR, then do whatever you can to do palliation for his obstruction. But advocate for no uncovered stent if you have any potential for surgery. The short gastric, the first step you do when you do surgery, you feel like great. Omentectomy, you're walking with your harmonic or ligature and you dissect all the way up to the greater curve. This is the biggest line of dissection, and you feel great. Keep going, keep going. I just remind you, you don't have to go generous. The first few surgeries I have done was so happy, excited, and I keep cutting, not knowing that I might need to leave some of the short gastric if I'm gonna cut the left gastric, right gastropapilloic, left gastropapilloic. What will supply that part of the stomach? So don't be super excited, leave some. You could go all the way to even this level to the lower pool of the spleen or even hilum, but don't go beyond that. You might need the short gastric if you want a good blood supply. We're going to talk about a few things. Then after you cutting the omentum, they talk about bursectomy. I'm not sure you're familiar with that term. So the bursectomy, I was try to be trained on that on my fellowship, to go and resect the lesser sac without violating. So don't see the posterior wall of the stomach. When you keep dissecting, you go, and the right plane is to lift the peritoneum, covering the pancreas, going all the way covering the retroperitoneum. So you're not seeing the posterior wall of the stomach. You keep dissecting and you skeletonize the peritoneum covering the stomach, and was like the way to go, especially when you have T4. So as if like you're removing the sac, investing all the potential malignant cells floating in the lesser sac. Turned out to be really time-consuming. Randomized control trial with multi studies showed that is not really of that benefit. Doesn't give you more lymph nodes, doesn't affect the survival, even disease-free survival. It's so astonishing. Like overall survival did not change. Even when they took that portion of the patient who has a cancer invading all the layers to the serosa, it's still not giving you benefit. How about disease-free survival? Less recurrence? No, it doesn't. How about harvesting more lymph nodes? It doesn't. So it came out of favor. I would not recommend it as we used to do. Complete omentectomy used to be the way to go. Take every inch of fat of the omentum, was historical, but multi-analysis also of meta-analysis of multiple studies showed not really affecting the survival. Omentum preserving gastrectomy is potentially oncologically safe and is accepted even by the Japanese guidelines, which they recommend if you have T3, T4, yes, you can do greater omentum, T1 and T2, more than 3 centimeters away from the gastropapilloic, you could preserve. And clinical trial underway in Japan showed non-inferiority and still more to be done. These are like some clinical trials randomized that showed like it's really increasing operative time, some intraoperative blood loss, and not really benefit of having more omentum. So it came out of favor. You don't have to go crazy after greater omentum. You could take, especially in T3 and T4, give you more like fibrofatty tissue, maybe more lymph nodes, but you don't have to go as we used to be more generous and remove all the omentum. D1 versus D2, I think our guidelines here recommending above 16 lymph nodes. Used to be 12, then moved to 14 and 15, and amazing. Like I got this wrong answer when they were comparing, they saying 15 or 16, and I was surprised there's like an exam that testing us on that. I think they're so detailed. 16 lymph nodes is the way to go. This is the total gastrectomy versus distal gastrectomy. What is D1? What is D1 plus? What is D2? I don't want to exhaust your time, but D1 basically is you go just around the lesser curve, greater curve. So if this is a lesser curve, this is a greater curve. So this is 1, and the other side 2. 3, the other side 4. 5, and the other side 6. So 1 is the uppermost of the stomach on the lesser curve, 2 on the greater curve. 3 is the lesser curve, 4 is the greater curve. 5 is a suprapyloric, 6 infrapyloric. So 1, 2, 3, 4, 5, 6. If you add to that 7, which is a left gastric, that's what we really, all of us do. Like there's no way to do less than this. When you're removing the stomach, you're removing the greater curve, which is 4, and lesser curve, and you're removing the pylorus, so you're removing 5 and 6. And most of us do 1 and 7, and kind of 2, most of us, when we do total. So D1 is doable. And when you add to D1, D2 is skeletonization of the branches of the celiac axis, the hepatic artery proper, the left gastric, the splenic artery, then you achieve celiac trunk itself, then you achieve D2. I think in between that is a D1 plus, which you're removing some of the common hepatic, which I think is very important lymph nodes to remove, and you get to the celiac. So that should be D1 plus. If you want to add to that the spleen, okay, but I think removing all the lymph nodes around the stomach, skeletonizing the hepatic artery and the celiac trunk, it should be a D1 plus, and that's what we really need. And I will come to some randomized control trial, Dutch trial, the British trial, Asian trial. They all showed like not major difference. I was like always like in the Dutch trial, we always comment on that. How come like this is 4%, 10% mortality? Is big. Like if I have that 1 out of 10 gastrectomy I do dies, it's a big deal in our hospitals. So I think this is kind of exaggerated. Wonder what is the reason for that. There are multiple trials, and it didn't show really huge difference between D1 and D2, especially D1 plus versus D2. So we, in America, we favor to do D1 plus, and I think D2 is also reasonable, and you could do it, but the study didn't show difference in survival. What are the margin when you cut in the stomach? That's quite challenging. If you have a tumor you can feel, that's great, but you wonder how much margin you can get. There is always concerning side, and you wonder which side is the concerning side. It depends. Like I always like go after the proximal margin, especially the esophageal margin. You cannot take too much if you are entertaining gastrectomy and going to the esophagus. But sometimes the pylorus and duodenum, if the tumor extending to the duodenum, I have like last week, tumor extending all the way down to the second portion of the duodenum, and I have to figure out where is the bile duct, do ICG. I try to do cholecystectomy and cannulate the cystic duct was obliterated for a certain reason. So I did ICG to identify the bile duct, laparoscopic, and just took my resection was 1 centimeter from the ampulla of water by the help of our advanced GI who came and saw the ampulla, and my resection was just 1 centimeter from that. So I always ink the concerning side. It's better to map your way. Ink anterior and posterior, greater curve, lesser curve, not too much inking because it can confuse the picture. So like the slightest, like maybe 0.1 cc in multiple spots. Sometimes work as a central lymph node because that ink travel to lymph node, so you can tell, okay, these are the lymph node that I have to resect, kind of sentinel lymph node like. Intraoperative AGD is a good tool. I always recommend that you get familiar how to use the AGD. It guide you, it make you feel comfortable about where you're cutting. Total gastrectomy I always send for confirmation by frozen. Do we got the squamous epithelium? We got the Brenner's gland. I really in the duodenum. I'm really in the esophagus. If I'm not, there's no reason to leave like a tiny piece of a stomach if you are going for total. In special cases, I'm coming at the end. The Japanese guidelines, they're recommending 3 centimeter for favorable histology and for 5 centimeter if you're dealing with a bad histology like signet ring or poorly differentiated. And if you cannot achieve that, which sometimes you can't, if you are really now at the esophagus or you're really, as my last week case, like you're really close to the second portion of the duodenum, you can't take more. At least you have to send frozen section. And to tell you, I like more than 80% of my cases I send for frozen section, confirm that I have a negative margin. That make me assured what I did while I'm preparing the RULEMP. For example, this patient is an Italian lady I did 2 years ago, and she has a very tiny lesion, T1A. We cannot do endoscopic resection because you could tell, I'm not sure you can appreciate or not. This is the cancer. Tell me now, like if you stick a scope, where is the cancer? I was super nervous when I did this lady. I took too much of her stomach because I asked my endoscopist, take a random biopsy, ink where you're gonna take that biopsy, go proximal as you can. So I cut the first portion of the duodenum. I know I got all the stomach distally, but proximally I was wondering, should I do total gastrectomy or not? She definitely declined that. I did a CDH1 genetic study, came back negative. But the lady said, definitely not, you're not taking all the stomach, leave some of the stomach. So when I did that surgery, you could tell, like, I'm not sure you can appreciate, like, it's really very subtle. Like, I was commanding my endoscopist here, how did you find that lesion? She said, honestly, I saw like erythematous mucosa at the pylorus. I took random biopsy. I got that surprising, poorly differentiated carcinoma. I was super worried. After surgery, she had negative lymph nodes, so we didn't give her adjuvant chemotherapy. I'm following her now for 2 years. She's still around with no evidence of disease. We definitely have to do more serial endoscopy. I give her just subtotal, and I lift a good portion of the stomach, maybe 10-15% of her stomach. Let me see. This is a video. Let me see if I can run it, of a gentleman who is a dermatologist, very nice guy. Came to me was gastric cancer in the lesser curve. I have to like figure out a way to leave enough stomach. So this is a left gastric artery. I don't know, you hear the sounds of the video?
Yes.
Okay. You hear that narrative?
No, we don't hear it actually.
Okay, so that stomach, if you see, I did technique here. I lift most of the greater curve, just here, like this is maybe midway in the greater curve, and I have to go tubularize the stomach to leave enough stomach for him. And here I'm close to the gastroesophageal junction. So I'm trying to, usually tubulization of the stomach, you do it more on the lesser curve when you do gastric pull-up, but this one was the opposite way. I cut the lesser curve and the greater curve. That stomach is tubulized toward the greater curve. It took a time to recover from that, and now is like I did it before Corona outbreak. So it's now 3 years. He sent me a picture. He's doing well. He got flat regimen before surgery. He got flat regimen after. No, he didn't get flat after surgery. He got 7 cycle of flat before surgery. He declined the 8th one. He surgery went fine. He didn't need anything after surgery, and currently no evidence of disease, and functioning very well. Very, when he sent me a picture from Australia with his wife, he's doing great. So that was rewarding. I will talk now about anti and retrocolic gastrogenostomy. The idea behind retrocolic is better, like drainage, and gravity will make the emptying of the rest of the stomach easier. We didn't see that, and we, all of us, I think, we might agree that anticolic easier, not complicating things, and faster. And if you need to go back to surgery for any reason, it's in front of you. You don't have to guess where is this loop that you have to work on to get any drainage or any further surgery. So studies for the Whipple pancreatic duodenectomy, anticolic retrocolic for the delayed gastric emptying, which is one of the major complications after Whipple. It showed, like all these randomized control trial, 5 of them was more than 500 patients. It shows no impact. They are the same. Anticolic, retrocolic, they are the same. Actually, some suggest even anticolic might be superior in a certain way. So, but no, they are the same. Anti or retrocolic, they are the same in gastric emptying. I'm extrapolating this data from the pancreas that I'm saying, just adopt this and use it for the gastrectomy cases. Again, another paper showing anti versus retrocolic is the same. No, and even lower incidence of delayed gastric emptying was anticolic. So the proximal gastrectomy, I think they were saying that if you go for board surgery exam, when I take my general surgery board before surgical oncology board, in the general surgery board saying, oh, you try to avoid saying central pancreatectomy in your exam. You're trying to avoid saying proximal gastrectomy in your exam. These are things that no one liked to hear. But I do believe there is a proximal gastrectomy indication for good favorable biology like T1, T2, moderate, well differentiated, or a GIST patient with a GIST. In these patients, you could cut the upper portion of the stomach, connect the esophagus to the rest of the stomach. I know everyone's saying, oh, this is going to be under tension, but there is some cases you might get away and you keep the continuity of the gut. Just remember, you have to do drainage procedure like pyloroplasty or pyloromyotomy. Sometimes I do pyloromyotomy and then I regret it. Patients still having reflux. The pylorus is not really wide open. So I ask my endoscopist to do dilatation, and patient doing fine after that. This is one of the patient I did also 3 years ago, just, and I did proximal gastrectomy. He came to me, he went to another major cancer center for a guy who was like, was almost my mentor, and he gave him like a decision for total gastrectomy. The patient came back to me, he said, no, I want to do what you suggested, proximal gastrectomy. So let me run the video. It's a gist. Look, the stomach really big, like long. It could go to the neck. So that stomach could go to the esophagus easy. This is a tumor that just, I'm not sure you see it.
Yes.
My right angle, you see my right angle is behind the esophagus. So I'm gonna cut here. I got good margin for the gist. Just usually you need like just negative margin. You don't have to take crazy 1 or 2, like even 1 millimeter sometimes enough. Of course, you shouldn't cut through the gist by any means. Violating the gist is something you're gonna regret the rest of your life. Like just cells floating in the stomach, I mean in the abdomen, and you lost it. You really lost it. So we did cut the esophagus here. I connected his rest of the stomach to the esophagus and negative margin. And 3 years now. I did it in 2000, literally like a week before the outbreak start and shut down the country. You could imagine shut down, like he left the hospital just before they tell us like no more surgery, stop everything. My kids stopped from school. It was a quite challenging time. He's still around, but this patient 100 times calling me and asking, oh, I have reflux, acidity. I give him pantoprazole, esomeprazole. I give him Pepsid on top of that. I give him Carafate. He still keep complaining. Finally, I sent him to endoscopist like maybe 6 months after being tired with his acidity and reflux. And once they dilated him, I didn't hear, oh, he's like, everything beautiful, eat and drink, and he didn't need any other procedure. He still follow me on Facebook, which I think I recommend if you have some patient you trust, they could follow up with you, so you know what's your survival status, and you can follow your patients. Row Y, gastrogenostomy or Belarus 2. My routine is row Y. I don't do Belarus 2. Study didn't show difference. You could do Belarus 2. There is randomized controlled trial in Singapore published about 5 years ago with 160 patients, and it showed not major difference, but there is higher heartburn, reflux, and gastritis, I think from biliary reflux. Rule lamp, I use 40 centimeter. The rule lamp, I use 40 centimeter, the biliary lamp, and usually that give me more satisfaction. Results, and I think I would recommend RUY versus Belarus 2 as much as you can. There is randomized control trial comparing RUY with Belarus 2 and Brown anastomosis, and Iranian trial is still going. The feeding tube, I only consider that for total gastrectomy. You don't want to lose nutrition in these patients. Anything will happen, and you don't have like a backup with a feeding jejunostomy is a disastrous. So I would recommend for total gastrectomy, especially in some patients. I prefer to do it in the candy cane of the biliary lamp. So if this is the biliary lamp, there is like the trouble that I have from the feeding jejunostomy, it narrow your jejunum. So you could have like a stricture and a patient having high pressure above that. So after you do the jejunostomy, use the biliary lamp. And I don't know how, like maybe this you're not gonna appreciate it, but in the real life is like the biliary lamp coming this way, curving, and you put the feeding jejunostomy here, you thread it to the common channel. I think that will work better. There is an entity of CDH1. I'm not sure you have how many patients you encounter in Egypt NCI or in your cancer centers in Egypt. But CDH1 is considered like a very exciting syndrome that we all care, and we have to consider, especially someone with a lobular breast cancer, ecadherin mutation and ecadherin negative. Some family member with gastric cancer, I send them for CDH1, and if they are positive, the 80% chance they will develop gastric cancer. Recommendation, definitely total gastrectomy. I will always add D1 plus lymphadenectomy, because it's your chance. If you get cancer, you need to know if the lymph node status is good and harvested. You don't have to guess after the surgery. And I always send frozen section for squamous epithelium that tells me, yes, I got all the stomach, and from the duodenum to Brunner's gland to tell me, yes, you got the duodenum. So all the stomach epithelium is out. So the take-home messages I would leave for you today: treat the C-word type 3 as a stomach. Always do endoscopic ultrasound and ink and map your margins before surgery. You cannot keep guessing while you're inside. You don't think that you're gonna see like serosal tumor all the time. Neoadjuvant, I will consider for T2 if you're American guidelines or European guidelines. Hispanic population, I'm not sure. I think Middle Eastern population is aggressive biology, and I will recommend also neoadjuvant in Egypt. But it depends on your circumstances. Patient might have difficult time to get chemotherapy, so it's an art of decision here. I will consider the FLOT regimen is superior if you have a good performance status. I will consider diagnostic laparoscopy to all cases, even before chemotherapy. Get an idea and get lavage and see if there is a peritoneal disease or not. Avoid uncovered stent by all means if you have any potential for curative intent surgery. I would say there is no level 1 evidence support complete omentectomy and bursectomy. If you want to do it, but you don't have to like kill yourself for it. D1 plus is universally acceptable. The margins 3 centimeter if you have favorable biology, histology. Unfavorable, you're talking about 5 centimeter. But if you can get a frozen section, it's acceptable. And sometimes you can go beyond in the esophagus, you can go beyond in the duodenum, like when you're close to the ampulla. Anticolic, I would recommend it. Roux-Y gastrogenostomy versus Belarus 1, I recommend Roux-Y. And proximal gastrectomy is still available option, but you have to do good drainage procedures like pyloroplasty, or at least do dilatation later when the patient recover from surgery. Consider feeding jejunostomy in the total gastrectomy patients. And think that bring me to the end of my talk. And I really welcome, I wrote comments first and then question. I really know what you're doing in NCI. It's an art of decision.
Okay, thank you, Dr. Basem, for this wonderful talk. Let's see if we have any questions or comments from the audience. Please, if you have a question, raise your hand. Any questions from the audience? Well, today we have less than usual attendance.
Yes, I see that. How many?
10.
Oh, we have 10 surgeons or medical oncologists, or what?
Surgeons.
All of them surgeons. Okay.
Yeah. Okay, we have a question from Dr. Walid Akmal. Please, if you have a question, raise your hand.
If you don't
Hello,
have
Dr.
questions, I
Basem.
have questions.
Okay.
Okay. Hello, Dr. Basem.
Ahlan.
Yeah, thanks a lot for your nice and wonderful presentation.
You're
I would like
welcome.
to ask you, if you please, 2 questions. The first one, how to endoscopically determine the 0 point of C-word? I mean, how many centimeters from the incisors? The other question regarding proximal gastrectomy, would you prefer a gastric tube, as you said, or we can try a double tract surgery?
Okay, first, let me take the first one. The C-word, you don't count the C-word based on how far from the incisor. This is You don't do that. You go and find the gastroesophageal junction, the squamocolumnar line, and look at the epicenter of the tumor. So you have the squamocolumnar junction. You know the transition between like a pale to pink mucosa. You know that line. You go above that line or below that line and see where is the epicenter. So you have that line in your EGD. You have a tumor. Look where is the center of that tumor. Is above that line, below that line, and how far, like really above the line. All what I care, if something like more than 2 centimeters below this line, the center of the tumor, below 2 centimeters below that line, the GE junction, the true GE junction, then it's a gastric. Do not stretch yourself. It's a gastric. Above that 2 centimeters, the center of the tumor, above that, then treat it as esophagus. Do not depend on the incisor. You need good endoscopist. You need to communicate. You need to go and plan. The endoscopist is never going to be a good surgeon. The good surgeon is never going to be a very good endoscopist unless very few of them. I know some surgeons, they do endoscopy. Like I think Dr. Ahmed Sami, right?
Yes, Dr. Ahmed Sami.
Yeah. So some Dr. Muhammad Gamil, some
Yes,
are
of course.
like, yeah, some are like really excellent endoscopy. But this you cannot like reproduce that in every surgeon because we focus more on surgery. And again, endoscopists also, they are not into what exactly they do. I would not say, oh, you have to be endoscopist, but at least you have to go and review it. If they have a video, you have to review the video. You have to discuss it with them. You have to tell them straight, where is the epicenter of the cancer? Is it above the GE junction or below the GE junction? And if it's below, is it really below, beyond 2 centimeters? Then it's treated as gastric. The second part of your question, Dr. Walid.
Yes, I was asking about proximal gastrectomy and reconstruction with a single gastric tube, as you mentioned, or versus a double tract surgery, esophagogynostomy, and then anastomosing the stomach to the jejunal limb.
Yeah, so there is a Merendino approach. You take a bridge between the esophagus. I think you could always, if you go for proximal gastrectomy, I used like the example that I put, like the GIST or a very early cancer. But if you are really dealing with a gastric cancer, I would really lean toward total gastrectomy. I save it for a very good biology patient with a very small gastric cancer, well differentiated or moderately differentiated. In these cases, I don't think you need to paralyze your stomach. I don't think you need Merendino approach. Every time you need Merendino approach or bridging or like a bypass approach or double tract, I think every time you're looking for that, then maybe the best is to do total gastrectomy. I have a Filipinian gentleman who's an engineer. I did total gastrectomy and esophagogynostomy. He's eating like as normal. So you could all, like after 6 months, you could approach almost normal results, not all the time bad. So I did Merendino approach. I remember this lady that I did Merendino approach was in my fellowship, came back with recurrence. So it tells me every time we're trying to cut short and to make it really proximal gastrectomy and need like a bridge or need double tract or need like something to bridge that gap, I think we are dealing with a bad biology. Just do total gastrectomy, clear everything. So that's my answer for that.
Okay, another question, please. Regarding Stewart's type 3, if you do a total gastrectomy and distal esophagectomy, and you decide you will do the anastomosis transhiatal, is it necessary to obtain a frozen section? Because if you have the margin, yes, if you could convert to an Ivor Lewis, right?
Because you could do the proximal gastrectomy and distal esophagectomy from the abdominal side. You could even open the chest. You could do it endoscopic and thoracoscopic. Laparoscopic and thoracoscopic. You could do all these, but instead of going crazy after the esophagus, feel where is the gross margin have a plan before surgery. You know where is the ink, and you cut above the ink a little bit, like 1 centimeter above the ink, mobilize the esophagus, and get frozen section. And if the frozen section is negative, you're done.
Okay.
Yeah.
Okay. Thanks a lot.
You're welcome. Okay, if you don't have question, I will ask you question what you're doing, so I learn. Do you do EOS for all the patient with gastric cancer? Yeah, Dr. Mustafa, you raised hand. This is answer yes, or this is a question? Dr. Mustafa Shazli. Do we have a poor signal? Dr. Hisham, do you hear me?
Hello?
Yeah.
Yeah, Dr. Mustafa Shazli?
Hello, you hear me?
Yes.
Now we do.
Yeah. Hi, Dr. Basem. Thanks for the nice lecture. And if you allow me to ask a question, do you do routinely the diagnostic laparoscopy with peritoneal lavage and looking for cytology?
Yes, I do it like a week before my surgery or before neoadjuvant chemotherapy. Yes, I do.
Yeah. And you do lavage and then centrifusion to take a cytology, or
Yes,
just
if there is a peritoneal fluid, I send for cytology. If there is no peritoneal fluid and the peritoneum is completely dry, I irrigate with 200 cc normal saline, suction it close to the stomach area, close to the tumor, and also I irrigate through like the Douglas pouch and send it.
That's great. Yeah. And what is the percentage that you find when it's dry that you find positive cytology? It's a high incidence, or I mean?
Not really, maybe 5% or less, 10%.
And this changed your decision regarding surgery, or it just they give you more
Yes, yes.
towards a neoadjuvant?
Yes, first these patients will take neoadjuvant. Some of them, they might get qualified for HIPEC, which is actually included in the guidelines now. But I tell you, it makes me how much enthusiastic about this patient. Like if the patient get deterioration during the chemotherapy, this is not the patient that is, oh, you know what, let me just cut it short and take you for surgery. No, he's not doing well on chemo. He probably had more than just a need for gastrectomy. So I would consider in these patients, continue the systemic, find immunotherapy, targetable genetics or something else rather than just jump for surgery.
And then you go for surgery, or you do another cytology later before doing surgery?
No, that's it. If you have diagnostic laparoscopy and peritoneal lavage and everything negative.
No, I mean if it's positive, and then he goes for neoadjuvant, and then if you feel that he is responsive, then you will go before doing another surgery.
I don't repeat it.
You don't repeat it.
No.
You go direct for surgery, right?
Yeah, but surgery, I do it laparoscopic, so you're gonna stick a scope anyway. But peritoneal lavage, I'm not repeating after chemotherapy. If it's negative before chemo, I don't repeat it after.
No, I mean if it's positive the first time, you would, and then he took neoadjuvant. If you're going for another surgery,
I would repeat
surgery,
it.
I mean, you repeat.
I will repeat it then.
And if it's positive, you don't.
I have to discuss with the patient. Some patient, if they have distal gastric lesion, have like favorable biology, and they are like in a good shape, younger population, not like terrible comorbidity, I will consider HIPEC for them.
Right. Can I ask a question? I found a patient. I got a patient 1 year ago complaining. She had sleeve gastrectomy 4 years ago, and then she was not well since doing the sleeve gastrectomy. And then she was referred to me 1 year ago with gastric outlet obstruction. I tried to take biopsy several times, but unfortunately it was negative. And then by CT, and so there was a big mass in the gastric antrum and pyloric, pre-pyloric area. It's attached to the pancreas and to the porta and so. And then all biopsies, whether by EUS and by endoscopy, was negative. Then we went for a feeding jejunostomy, or we decided to do feeding jejunostomy because she was obstructed the outlet. And then when I opened, I took biopsies, several biopsies from the omentum and from the outer surface of the tumor, and it proved to be something strange, plexiform fibromyxoma, which is, it's reported in the literature. Small number of cases were reported like this. I don't know if you have experience with such a pathology or not. And I'll continue to the story of the patient, if you don't mind.
Well, I would rather take that in a separate side discussion, but fibromyxoma, there's a chance this is a low-grade fibromyxosarcoma, and the patient in this case need like a surgery.
But I couldn't go for surgery because for this patient I had to do Whipple because it's attached to the stomach, to the head of the pancreas, and to the porta hepatis and so.
Well, it depends. Like if it's a fibromyxoma, usually it is not infiltrative. Is more pushy. The sarcoma usually not infiltrative. If it's infiltrative, there is something else. The diagnosis is not right. So, but it's we could chat about it like on a side talk. You could take my contact from Dr. Hisham and we'd chat about it. It's an interesting case for sure.
Yes, Hisham, please inform me the
yes,
contact. Okay.
Okay.
Thank you.
Okay, Dr. Antar.
Hello.
Hi, Dr.
Yes.
Antar.
Hi, Dr. Basem. Thank you very much. I'm Dr. Antar, surgical oncologist from Yemen. I have two questions.
منين دكتور عنتر؟ من اليمن؟
من اليمن أيوه.
أهلا بيك.
بس أنا كنت في معهد الأورام في مصر 10 سنين.
تعرف دكتور سعد الشبرين؟
أيوه طبعا أعرفه.
اوكي، صديقي العزيز.
طيب كان هو رجل قصر العيني برضه.
يا كان دفعتي. تفضل.
بالضبط. I have two questions. Number one, if we have lymph node metastatic from gastric cancer or gastroesophageal in the porta hepatis or celiac or para-aortic, considered metastatic or loco-regional. This is the number one. Number two, sometimes we have metastatic gastric cancer as mild ascites, omental nucleus, peritoneal nucleus, and after chemotherapy, complete response. Can we do surgery or no?
The answer for the first one, para-aortic and superior mesenteric lymph node in the root of the mesentery, it's I would consider that metastatic, and I would give the patient chemotherapy indefinite. I would not consider a gastrectomy unless a rare scenario like they live for 1 year, they're doing great, then I might consider going after that. That's for the para-aortic and superior mesenteric. Celiac, I'm okay to resect. Hepatic, splenic, that's okay. The second portion, if you have omental caking and you have like lymph nodes, we have to define, are we dealing with peritoneal disease, omental caking, or like deep, like parenchymatous, like something deep inside the liver, or like big lymph node, bulky? If a big bulky lymph node, para-aortic, so it's more than just a surface malignancy. And HIPIC is not the key. HIPIC usually for peritoneal disease, but you could, if the patient living for a year was very good shape, the disease is very limited, you may stretch your limit and do HIPEC, do gastrectomy. I don't like to do total gastrectomy for HIPEC. I don't think doing esophagogynostomy. I would rather do subtotal gastrectomy and lavage the abdomen. But it's interesting topic. I think I will offer HIPEC for someone who had like prolonged survival after chemotherapy with limited disease.
Does that answer your question, Antar? Okay. Okay, Dr. Mahmoud Khalil.
Hello. Thank you, Dr. Basem. Thank you, Dr. Hisham. I'd like to ask after subtotal gastrectomy regarding the anastomosis, do you prefer a technique, certain technique, to do it either longitudinal transverse, anterior, posterior to the surface of the stomach to avoid an island or ischemia?
The stomach is so vascular. So I see your point. You're trying to lead me to, you have a staple line on the stomach, and
Yes,
then you wanna do another staple line. Where it's gonna be? So should you go for the angle? Should you go with a stapler? Should you go? I usually see the staple line. I go like about 1.5 centimeter proximal to that, and I do another line, either vertical or kind of an angle of 60 or 70 degree, and I just fire another linear like in the GIA stapler. And that usually I didn't have a patient who have like an island of ischemia. Most of them, they do well. So I avoid this. I avoid going flush to the other staple line, and avoid like a parallel staple. So I go like either perpendicular if I can, or 70 degree or 60 degree, but not like 20 degree, like I'm not sure, like you see, like if you go like a V shape or sab'a or tamania, that's a very like sharp. So I try this, like I try to go like 60, 70 degree. So there's not too much like a strip of the stomach is completely devascularized. But I tell you, stomach will take any hit. Stomach is a good organ.
it is better to do it on the anterior surface or the posterior
I
surface?
usually do it posterior. I find it more like by gravity, and it's better. It lay better, and it work as actually the rest of the stomach, kind of a ceiling or a serosal patch on top of my anastomosis. So I do it in the posterior.
The size of the anastomosis about 3 centimeters is enough? Or
I usually fire a 60. When I say 60 millimeter, which is a 6 centimeter, endo GIA, I use a 60 load, and the 60 usually end up like you're losing 1 centimeter above and 2 centimeter below, so you end up with a 3 centimeter in the best scenario. So I use 60.
Okay. Thank you, Dr. Basem. Thank you.
You're welcome.
Yeah, any other questions? Please, if you have a question, raise your hand. Well, I think we don't have any more questions.
So I can ask you like a few questions to know what you're doing. You do endoscopic ultrasound in most of your cases, Dr. Hisham?
No, I wouldn't say most of the cases, and sometimes it's not working. And
Okay. How about like bursectomy or mentectomy? You still doing like aggressive omentectomy, bursectomy?
I think omentectomy at least, yes.
Okay. And how about neoadjuvant? Most of you, like if you have
We tend to
invasion,
send most of them into neoadjuvant. Yeah, we try to. I think in the whole field of surgical oncology, there is a shift towards sending to neoadjuvant first. Even now, and now they're talking about resectable pancreatic cancer, even send them to neoadjuvant. And
yeah, you know what? In the last ASCO meeting this month, when they had it, the Nordic Panc trial didn't show survival. Was neoadjuvant resectable. So I think currently we take resectable to surgery in the United States. We're trying to see if patient has a big time weight loss or any other like high risk feature. But in the stomach, I would say if someone has extensive weight loss, not justified by the obstructive symptoms, or like a high risk lymph node status on the CAT scan, or very bad biology, or like endoscopically looks like terrible disease, these patients I would send for neoadjuvant.
Okay.
All right. Well, as always, interesting and pleasure to me. I'm one of you. I like to see these new names. I'm not sure like what level, but either you're above me or like or junior than me, or so it's always pleasure to join that forum.
Thank you, Dr. Basem. Always a pleasure having you with us, and looking forward to the next time.
Thank you.
Okay. So
Have a
see you
good
all
night.
next week.
Yes.
Thank you all for joining us.
Good night.
Goodbye.
Goodbye.